Good afternoon, everyone. I'm Alex Voorhoeven. I'm Vice President and Pro-Vice Chancellor for Faculty Development at LSE. I'm also Professor in the Department of Philosophy, Logic and Scientific Method, and I've worked extensively on fair priority setting in health. So today is of dual interest to me, and of course, I'm sure of special interest to everyone here and the extraordinary number of people who've joined us online. I'd like to welcome you on behalf of the LSE to this event, Maternal Psychological Wellbeing, a challenge and a unique opportunity. We're really honored to host this event, which brings together policymakers, administrators, academics, clinicians, advocates, people with lived experience, and all those committed to understanding and addressing one of the most critical but often overlooked aspects of maternal and infant health, perinatal mental health. In this event, LSE joins forces with Make Mothers Matter, Anna Freud, and the Care Policy and Evaluation Centre, also known as CPEC, to present studies that will make a case for two conclusions. The first is that maternal mental health is one of the most pressing and most overlooked public health challenges of our time. It affects parents, children, families, workplaces, and economies. Second, that there's a valuable opportunity to intervene early, reduce long-term harm, and build fairer, more effective systems of care. Now, based on my own work in health policy, which is from a philosophical perspective, arguing for the criteria that we should use in order to decide which interventions to prioritize, which include, but are not limited to, the total impact on health, but also the ways in which the intervention can reduce inequalities along a number of dimensions. I'm very sympathetic and I'm keen, as I'm sure all of you are, to hear the details of the case presented for these two conclusions. But I'm also from a department of philosophy, logic, and scientific method, which was founded by Karl Popper. And you may know that he was famous for the claim that the scientific method itself is, in its essence, exposing your own arguments to the greatest possible critical scrutiny. So today, in that spirit, is not just about hearing an argument in favor of some conclusion, but rather the distinguishing mark of science and of what we're trying to do here today is to expose to criticism, to critical scrutiny, the findings that are put before us. Now, Karl Popper, in fact, said that those of you who are about to present those findings should yourself expose them in public to the greatest possible critical scrutiny. You should do that job yourself. But he also mournfully observed in the introduction to his book, Conjectures and Refutations, no one will do that. He was himself known for flying into a rage when others criticized his arguments in the philosophy seminar just around the corner here. So, knowing himself, knowing ourselves, he said, this is unfortunate about human nature, but fortunately, others will supply the criticism for us. So all of you online and in the room, not presenting the findings, you will excuse the presenters. The presenters can make the strongest possible case as they see it for their conclusions. But all of you are invited in this Popperian spirit to question, to criticize, to engage with the evidence that's put before us. If it passes the test of your critical scrutiny, then we will have even more reason than we had before to accept the conclusions. But I want to add one further thing. Today is not just the seminar room testing out the studies and their ideas. We're also here to explore what would follow if you accept these findings, not merely for what we should believe, but for what we should do. Which actions should we encourage the state to take which action should we advocate for, which action should we take if we ourselves are among those in the levers of power. So in sharing this research, in opening it up to scrutiny and exploring its policy implications, this event exemplifies, as well as any event could, LSE's founding mission. Our slogan, many of you will know it, to know the causes of things, but then we can add to facilitate knowledge exchange that then contributes to the betterment of society, the second part of our slogan. So we at LSE take pride in fostering discussions and initiatives that bridge the gap between research, policy, and practice. And over the course of this afternoon, we're going to hear from leading experts. We're going to engage in meaningful dialogue, constructive criticism, and explore innovative solutions to strengthen care and support systems for perinatal mental health worldwide. Before handing over to the main event, I want to thank our partners Making Mothers Matter, Anna Freud, Dr. Alain Gregoire, our distinguished speakers and panelists, and all of you joining here in the room and online. All of you bring knowledge and experience and critical scrutiny to this event. We've come together to learn, reflect, challenge, and put knowledge into practice with the aim of contributing to societies in which more people have the support they need to thrive and more children can grow up in a healthy and nurturing environment. Welcome, and let's get to it.
Thank you very much for that warm welcome, Alex, and welcome, of course, to you all here in the room. It's fantastic to see this turnout from so many different sectors and parts of society, and welcome to those on, I'm not quite sure where I'm looking at, welcome to those online, over 600 people joining us online, and of course welcome to those who'll be watching the recording that will be available as well. I'm Alain Gregoire. For 40 years, I've been working in perinatal psychiatry in the UK's NHS, and I have the great pleasure and honour of being the honorary president of the Maternal Mental Health Alliance, which brings together well over 150, I think now, national organisations across the UK. The fact that we're all here gathering together to have this conversation about this issue, I think is a testimony to the fact that we care about those who are involved in nurturing the next generation, those who we all rely on as a society to nurture the next generation. And those people, mothers, birthing people, parents, who are doing actually the most difficult job that any of us ever do in our lives, juggling conflicting commitments sometimes, and certainly multiple commitments, where the whole concept of choice barely exists. We just have to get on with it. And I was hearing somebody phoning into a radio program talking about just this in the car this morning. You know, I don't have any choice. I've got to do all of these things, but it's taking a toll on me, this mum was saying. And that's also part of what we want to consider today, not only what all those commitments are, how they're impacting on mothers, birthing people, on parents, but also the impact that then has. You know, if you keep hitting a bone often enough with a hammer, it will probably eventually break. And our minds aren't really that different. If you keep stressing them, we all know, because we all experience it to some degree, our minds will suffer. And for some people, for all sorts of reasons, will suffer even more. And we know the science tells us very clearly that relationships are fundamental to human survival as well as human well-being. And there is no time when that is more important than when we are involved in nurturing the next generation. It's relationships that get us through those difficult times. And support, we know from the science, support, emotional support and practical support. You know, your app cannot change the baby for you. You've still got to bloody well do it yourself, you know? And so that emotional as well as practical support remains at the core of the role of nurturing that next generation. And that is an enormous challenge for us. And we as a society need to step up to the mark better than we do, because we know that the impact, the negative impact on mothers, on birthing people, on parents is huge. And so we'd like to explore some of the ways in which we can step up at the very beginning. So you'll be hearing a bit more about the challenge, and you'll be hearing a little bit about a number of possible solutions, and we're going to focus today particularly on what we can do at the very beginning to be more nurturing of that psychological well-being, but we are also expanding the conversation beyond that with the panelists that we have and the contributors that we have, and I'm sure with the audience that we have. So we're going to start with 3 presentations, and then we're going to have some comments from a number of people from diverse perspectives here in the room today. And then we're going to move to a discussion with a panel and some time for a few questions and answers. And we're packing all of that into this very short time. So I better shut up and get on with it, in fact. And I'm going to hand over to Shanaz, our dear friend Shanaz from Make Mothers Matter, who were the instigators of this compound day, considering so many different things. So Shanaz, I hand over to you.
Very much, Alain. He's such a great raconteur, isn't he? Even he could be talking about anything, and we'd listen. Welcome to all of you here in the room on behalf of Make Mothers Matter, and the figures that you just said, 650 online audiences. So thank you for joining us as well. I suppose what it shows is just how much this topic resonates. And this morning, The Guardian kicked off the conversation with headlines asking, how bad is maternal health in Europe and how can we fix it? And another article, 7 out of 10 UK mothers feel overlooked, research reveals. And in a moment, we will reveal those statistics. Now, both articles were referencing our State of Make Mothers Matter, State of Motherhood report, drawing on nearly 10,000 mothers that we spoke to. So this is what 10,000 mothers across 11 countries in the EU and the UK said to us. And putting their experiences front and center. Over the past year, we've taken this survey, and my colleague Angela, who you'll hear from in a moment, right across Europe to parliamentarians, activists, campaigners, media, anyone who would listen to us, to ensure that mothers' realities are heard, because these are not just figures, these really are experiences. There were some great quotes in the article, Alain, if you will allow me to just quote a couple of them, because they reinforce how mothers everywhere face pressures that affect their well-being, not just their own, their families, and the larger communities. These, again, as I say, are not numbers. These are real families, real lives, and a reality I think we can and must change. So one of the quotes was Dr. Natasha Azopardi-Muscat. Some of you may know her. She's the Director of Health Systems at World Health Organization Europe. She said, the findings show that mental health strain is the norm, not the exception. Imagine, especially for mothers with young children, multiple children, low incomes, or single parent households. Yet caregiving during early childhood is one of the most powerful determinants of lifelong health and well-being. And then there was another quote, Anne-Catherine Orr, who's the policy officer at Mental Health Europe, and she says mothers' mental health is deteriorating because they face huge challenges, too often without support, and crucially, because policies haven't caught up with them. They haven't caught up with the reality. You can't pile work pressure, care responsibilities, and rigid gender norms and roles onto women while reducing social supports and then be surprised when anxiety and depression rise. So some things for us to think about today. I'm sure Alain will continue to remind us. I have one more job to do before I hand over, some housekeeping notes. In case of a fire alarm, it will be a real one because there's no tests planned. And what you should do is take the closest exit to you. There's one there and one there. Please do not take the lifts and follow Dr. Annette Bauer, whom you will also hear from shortly. You will be taken to the meeting place outside LSC at Lincoln's Field Corner, right?
Yes.
Okay. Online, we've got a live chat that my colleague Ariane is running. Do drop your questions, our lovely audience, into comments, and we'll try and cover, as Alain said, as many as time permits. Restrooms, through this door, through that door, and all the way over at the end. We are recording the event live, and please remember to turn your phones back on when you leave. Right. I'm thrilled to hand over to Angela Garcia, who's Make Mothers Matters Projects Director, and she's been at the helm of this survey from the get-go to see what it tells us for the UK.
Hello, everyone. Thank you, Shanaz, for the introduction. Before I begin, just to let you know, if you scan that QR code, you will access the full report that I'm about to present. Well, before I begin, I want to say that beyond my role at Make Mothers Matter, I have another very important role, and this is that I'm a mother of two boys, aged 6 and 8. Like millions of mothers, I contribute to society through both my visible and my invisible work. Work that requires time, energy, money, and skills developed through mothering. I say this intentionally because motherhood is still too often invisible in professional and political spaces, despite being one of the most essential contributions to society. This is exactly why Make Mothers Matter exists, to give mothers a voice, representation, and rights, so that society recognizes their essential role and takes care of those who care. Today, we're pleased to share some key findings from the State of Motherhood in Europe 2024 report. We conducted this survey in collaboration with Kantar to let mothers speak for themselves, to understand how they actually live and how they actually feel in a context where robust data around motherhood is still largely missing. Our report, based on interviews with 9,600 mothers across 12 European countries, including the UK, has a clear picture. Mothers everywhere are under intense pressure. It is not an individual failure, nor a country-specific issue. This is a structural crisis. In the next minutes, I will give you some data about 3 topics: maternal mental health, workplace, and the lack of balance in care responsibilities within families. In the graph that I will show, you will see the European data in light pink and the UK data in dark pink. Our most sobering finding is this one, is that a majority of mothers experience mental health challenges. 67% of mothers report feeling overloaded. This rises to 71% in the UK. Even more striking, 1 out of 2 mothers said that they have experienced at least one mental health issue. And looking closer, we see that The UK is above the European average for both depression and anxiety. We also ask mothers what helped them during those difficult moments. They have mentioned having more time for themselves, precisely what most of them don't have, support from family, partners or friends, or medication. Public support appears at the very bottom of this list. What this tells us is clear. Mothers are largely left to cope on their own, relying on private resources, time, money, networks that many simply do not have. Care systems are absent. And this is how mothers themselves describe it. They feel lonely. They feel abandoned. In the following presentations, our partner at Freud will show how the situation can be improved by integrating psychological support for common perinatal mental health difficulties into universal services and the positive impact this can have. So we've tried to understand in the data these pressures. Why are mothers suffering? We've identified several structural factors that are not unique, and today I will focus on two. The first one is the workplace, because while mothers are constantly adapting, becoming more flexible, more resilient, workplaces do not. 27% of mothers stated that motherhood had a negative impact on their work or careers. And in the UK, this rises to 31%. We see how mothers adapt to this rigid work environment. 23% reduce their working hours, 34% in the UK. 55% changed their working status, moving to part-time work, self-employment, or leaving standard employment altogether. And this figure is even higher in the UK. In practice, this negative impact means a lot of things. Lower incomes at a time of higher expenses, fewer learning or career opportunities, feeling undervalued or excluded, discrimination during the recruitment process, and yes, in some cases, even job loss. And how do mothers respond? Well, most do not take action, but not because they accept this injustice, but because of real barriers, lack of time, high legal costs, limited information, fear of retaliation. Today in our panel discussion, Anna Whitehouse, founder of Mother Pucca, will highlight why flexible working conditions are essential in addressing these obstacles. The second factor I want to highlight is the unequal distribution of care responsibilities within families. Up to 70% of household and caregiving tasks are handled by mothers alone, regardless of their employment status. The pressure doesn't stop at work. It continues at home. This is the invisible work. Most mothers also remain the primary caregivers of school-age children, well ahead of fathers, extended family members, or paid support. And when we look at fathers' involvement in early care, 37% of the European sample took no or very, very little paternity leave. In the UK, this is 90%. But let's bear in mind that here, paternity leave is just 1 or 2 weeks, far too short to support mothers, babies, and the transition to a new family balance. Despite all this, motherhood remains an enriching and meaningful experience. Actually, 80% of emotive words mothers in our survey used to describe motherhood were positive. And yet, many mothers still do not feel recognized by society. Motherhood is not the problem. The systems around it are. And today, as I said, our partners will highlight some of the ways these systems can be changed, improved, solutions to support maternal mental health. But there are many other challenges that still need to be addressed. As I said, creating more flexible workplaces, improving maternity and paternity leaves, changing mindsets, gender stereotypes, so that every mother and every father can truly choose how they balance caring responsibilities and their careers. As I said, if you would like to access the full report, you can visit our website. And thank you for listening and for being here as part of the change mothers are calling for. Thank you.
Thank you so much. So you've heard that things haven't changed. None of us, I think, in this room or probably in the audience either, are particularly surprised at these findings. They are shocking. A huge proportion of our society doing the most, well, I won't go on about it again, but the most important job that any of us ever does are suffering in this way and suffering this sort of disadvantage in life. But we have known about this for some time. And yes, we have been reflecting on the consequences and the sorts of things that could be done. And we do have paternity leave, 2 weeks, and we do have maternity in the States, of course. We don't have any at all, but, you know, I don't think anybody really wants to be like the States anymore. So we've been reflecting on this, and one of the areas of investigation has been the economics of it, because in order to persuade those who have the power to prioritize investment, and in particular public investment, need a good economic argument to do the right thing. Just it being the right thing isn't quite enough. And Annette Bauer has led a lot of the work internationally in relation to maternal mental health, the consequences of these sorts of pressures, and she's going to tell us a little bit about that. So Annette, thank you very much.
Thanks so much for the introduction. And yeah, it's really nice to be here and welcome to everyone. And so I'm going to attempt in the next 5 minutes to make 4 simple points. So first, doing nothing about perinatal mental health is costly. Second, we are still missing major opportunities for early support. Third, early support through integration can work and is good value for money. And finally, I will point to a realistic and affordable way forward that we can discuss critically. Okay, so first, I always feel like I need to almost like apologize or at least explain why economic evidence matters in this field. As many people think, it's about counting costs. So it is actually not about counting costs. It's about how we use limited resources to improve well-being. And resources are always limited. And then there's another point, there's another misconception. Costs are not just about how money is spent. It's a measure of time, effort, and lost opportunity. So, for example, when perinatal depression is not identified early, the cost is not just a later referral or prescription. It is months of distress. It's time of work. It's perhaps attempts to kind of get help. So it's visits to the GP. It's reduced caregiving capacity to look after the child. It's pressure on family, and often more intensive and more expensive care later on. And these kind of like questions shaped exactly the work we have been doing in the field that by myself and colleagues at CPEC at LSE for more than a decade now. So in our 2014 study, we estimated that the cost of untreated perinatal mental health problems cost around 8.1 billion per birth cohort in the UK. And this was actually using a conservative approach in the sense that we didn't actually have all the evidence to kind of like make those cost assumptions or cost estimates. And there's still kind of like conditions for which we don't know the impact of. But for a lot of conditions, we actually have good evidence about the short-term and long-term negative impacts that perinatal mental health has on mothers and on children that are now really well evidenced in the UK and internationally in often really nicely conducted and so important birth cohort studies. And so that's usually the point, the time where I always highlight the importance of birth cohort studies, because without those studies, we really wouldn't know about the intergenerational impacts, and we would not have been able, obviously, to quantify the economic impacts either. And so on the slide, you can see that about 20% of the costs are public sector expenditure. So that's the cost that government usually cares about. And they're spreading across a wide range of sectors and services over the years. And the substantial amount of money is the majority of costs, around 80%, and that's borne by families and society. which reflects the invisible cost we must consider when thinking about improving well-being. And so the central message is simple. Failing to act is not cost neutral, it is costly. And so since the study came out in 2014, it informed kind of like major progress or investments into specialist perinatal mental health services, including what we have in the UK as mother and baby units and specialist community mental health teams. And these are essential. They're well regarded and life-saving for women with complex and severe needs. But number-wise, most women actually experience common mental health problems, so depression and anxiety. And that's where access still remains limited. So it's estimated that only 1 in 3 women with a diagnosed mental disorder have access to treatment in the UK. And access issues are complex. They're not simple. Many are related to stigma affecting 1 in 2, but stigma indicates broader issues, broader system issues about fragmented systems, a focus on clinical needs rather than the person, and also discrimination. And Camilla will pick up some of these points in her presentation. But I think it's so important to really highlight access is not equal. We know, for example, that Black women are around twice as likely to be admitted in crisis situation, often when early help was not available. And so this is why organizations like the World Health Organization or NICE or the European Commission, they recommend integrating mental health into maternal and child healthcare to close this gap. And this is informed, all these guidance are informed by a really large body of evidence showing that training staff in routine inquiry and psychosocial treatment and support is effective in reducing and even preventing maternal depression during pregnancy and after birth. But obviously this evidence is from trials, right? And so obviously we need systems that can actually offer this kind of support at scale. And that's where potentially integrated care models come in that incorporate the principles of task sharing and shifting. And they really matter because women are already, especially for the perinatal period, because women are already in contact with health services at that time. And so there is an important opportunity for early identification and support at this point. And then obviously this idea is a vision. It's based on a big assumption that those services are or can be transformed into services that are mental health friendly. And that's a big discussion, I think, and hopefully we can have that discussion today. And Camilla will talk about some of those challenges and opportunities more in a moment. However, sticking with the research for now, we know from several UK and international studies that with substantial effort that is often made in those studies that is not talked about, this can be achieved. So we have some really nice studies from the UK showing that training midwives and health visitors, so that's the staff that is providing support to women after birth, and they're equivalent to family nurses, for example, in some countries. So having these kind of like staff trained to routinely ask about mental health and offer low-intensity psychosocial support is not only effective, it's also cost-effective, with an 80% probability of being cost-effective. And that is just based on short-term quality of life outcomes measured in those studies for women. So that's before considering any kind of like longer impacts on women or children. And importantly, we also found more recently by reanalyzing some of the data from the studies that this approach also benefits women with subthreshold problems, which suggests that having more mental health friendly staff who know how to talk about mental health is cost effective for high and low risk populations, and therefore it should be argued that it can be delivered universally. And so this is exactly, again, this kind of like background and using exactly this kind of evidence. That's where we started doing our modeling study in 2022, using evidence, using NHS data, other statistic information from UK published sources. And we estimated unmet needs and examined the costs and benefits of early identification and low intensity support and treatment delivered through an integrated care model in the UK over 10 years. And we found a net benefit of around 490 million over 10 years, with upfront costs recovered quite quickly. And so I should and need to highlight that the majority of the benefits stems from quality of life gains that we estimated at providing 1,420 additional years in full health. And then there were also additional smaller cost savings over the 10 years period of just over 50 million. And that's in pounds. And that's, again, before considering any kind of like longer term effects on women and children or the wider system. But obviously in that modeling, we had to make simplifying assumptions about, for example, what integrated care looks like. And so I would argue, and again, we can be critical about that, but the question is no longer necessarily whether integration makes economic sense. We think the answer is yes, but that's in principle, right? So it's all about how to implement it effectively and cost effectively. And that's exactly where Camilla, the next presenter, will come in and focus on.
Thank you very much. So you've heard that there's an enormous challenge, and there still is, and we haven't resolved it. And actually, in the UK, I think I should really emphasise that the NHS has done a fantastic job, and government has done a fantastic job in investing money, time, and energy in the care of women who have the most high risk, the most complex types of mental health problems. But that's only 10% of the women and their needs. The vast majority of women who have mental health difficulties have what we usually call common mental health problems, so anxiety and depression. And that's what this sort of study has been focusing on, and that's what Camilla is also going to be discussing in presenting the new report that is being launched today, I think is right in saying, by the Anna Freud Centre, which is the culmination of months of work investigating the reality on the ground with a number of different stakeholders of this challenge. Is it actually feasible? Is it possible to do integrated care in the way these big international bodies are recommending it should be done all over the world, in the way in which the economic studies are suggesting would be cost effective? Can we actually do it? I'm going to hand over to Camilla to answer the question.
Fun start, right? Perhaps Annette, you can have a look and I'll introduce myself. So it's lovely to be here. So wonderful to see so many friendly faces, and like everyone said, have people online. I'm Camilla Rosen, and I am from a wonderful mental health charity, Anna Freud, which supports children and families. And I'm trying not to parallel that's where and add my slides.
Okay, I'm going to take charge in this situation. I'm going to do my role as a chair. After Camilla's talk, we were going to have some comments from the floor from a number of people with various perspectives on these issues. And I'm going to preempt this while we find Camilla's slides. They do exist, so they must be somewhere. And I'm going to ask a number of people for their views on this issue, this topic, despite the fact that they haven't heard Camilla's presentation. So I'm going to ask, for a start, with actually Elizabeth Clough. Now, I saw you somewhere. Hello. So Elizabeth, who's from the NCT, and I'm going to start with you, Elizabeth, because no, because there are microphones on the ceiling, and I think our audience online should be able to hear you by the magic of the ether. But Elizabeth, I'm starting with putting you on the spot for a very quick comment, because the NCT conducted a really inspiring piece of work a number of years ago, documenting the barriers that women experience to receiving care. And I'm sure you can tell us a little bit about that and a little bit about the other work that the NCT has done in this area.
That's right. Thank you very much, Ella, and I'm so delighted to be here today. I used to be a policy advisor at NCT, and I've just morphed into being president, which is a great honour. So delighted to be here. You're absolutely right about NCT became involved in awareness raising about perinatal mental health perhaps 12 years ago. We joined the wonderful Maternal Mental Health Alliance, led at the time by Alain. And we worked out what we were able to do with resources at the time. And about 8 years ago, we launched a campaign called Hidden Half, based on very well established data showing that at least half of women suffering mental ill health around childbirth were not getting the treatments they needed. We identified, and it is pretty well known, at least 3 major barriers. One was women's perceived and real stigma about acknowledging to themselves they had a mental health problem and or their partner recognizing it. It was then finding someone who could offer some help. And in those days, this was really tough because you could ask a midwife, you could ask health visitor, you could ask a GP. Most of them were very sympathetic, but they were not clinically trained to provide that help, and they knew no service that would do it, that was in any way local. Sometimes women were then referred to a service that might help, but there was a long, long waiting time because so many people needed that. So those barriers, some of them, as Ala has highlighted, have been addressed and partially removed, which is great. More women are getting the help they need. One of the goals of that campaign was to get the GP's postnatal check for mothers at 6 to 8 weeks mandated, and we achieved that. We achieved that on April the 1st, 2020, neatly timed to be about a week after the whole nation locked down and no one was able to speak to it. It wasn't great timing. However, we know that more women now are being able to get that check, and that check must contain real exploration of the woman's mental health. It isn't the only thing that NCT has done. We established a programme which takes place many places around the UK called Parents in Mind, which is a peer support programme which has been extremely successful with women with those so-called moderate issues, but sometimes really very, very hard for them. Peer support works well, and we've been able to get our volunteers trained, and some of them move on to better things within that sector. Just very recently, last week, we launched the results of a survey called From Expectation to Reality, which has been quoted again in the press today with relevance to this meeting, showing the large numbers of women struggling, feeling overloaded, feeling before the birth, anxious about so many things, and seeing their mental health sometimes going downhill and falling through the gaps in this still very fragmented postnatal care. I can see Alan looking like I must shut up now.
So you documented huge barriers that women face and fears that they face, partly related to the system. Some of those overcome, but still huge unmet need out there. And we have the slides. I have my back to everybody. We have the slides? Yes. Okay. We'll move on to some further comments after the presentation.
Hey again, everyone. I feel like perhaps I'm modelling what it is to be a mum and juggling all these different stresses that crop up in life. So I'll try and kind of get back in my presentation headspace. So I was thinking then I might just have to do it off the cuff. Anyway, it's absolutely lovely to be here. I'm Camilla. My background is as a consultant in perinatal psychology, and I am a researcher at Freud. And I had the privilege to lead this wonderful project about something very dear to my heart. I worked with this great team of people here, and it was a really co-produced project. So Lani Richards led the Expert by Experience kind of work stream in the project from her own lived experience, but also that was a huge part of what we were doing. We were really trying to understand from all perspectives what is the best way of integrating services. So what does it mean to parents? What does it mean to service managers, frontline practitioners and commissioners? And they were all part of the people that we kind of explored this idea with. So lots of this background you've heard. And I think it is important to say again, this is really taking a UK, but really an England focus on how we can make integration work based on the systems we have. We are so lucky to have amazing specialist NHS perinatal mental health services. They have done a huge amount, but they work in England for the moderate to severe and complex. And rightly so. But there is a huge group, and in England, based on the data that we have from NHS England on how many people access those services and our birth rate, we know that there is still 115,000 people that don't meet the threshold for those services. That is a lot of women and birthing people that are struggling but aren't getting support. And this idea of common mental health or mild to moderate mental health difficulties, these terms are kind of difficult because often something that might be termed mild by services doesn't feel mild in its impact. And the impact particularly on a person's ability to function, like we've heard, get back into the workplace, get back in the same way, to be able to parent in the way that they might want to. Things that are really important, but it's also the kind of chronicity of that. So if we don't get in early and help people when they need it, how they want it, then these things could become more severe. And that's when it costs lots of money. That's what Annette has done an amazing job of illustrating. And we know we are seeing these huge costs in our, inpatient and secondary care mental health services by a small number of people. Perhaps if we got in early, really early intervention, this could be different. And that's what we're trying to work out here. And I think the thing that is really tricky is how do we do integration in that context? What does good look like? I'll talk through that a little bit, but one of the things that's particularly challenging in the UK, but perhaps wider, is that although we know from Annette's work and other studies that health visitors and midwives, those kind of frontline universal practitioners, can and do a beautiful and elegant job of providing support, they are already doing so much, facing so many barriers, and we don't have enough of them. We don't have enough of them to do that primary job. So we need to think creatively about who can provide this support within our workforce, which is what we've tried to do. So as part of the project, we did a rapid scoping review to look at all the international literature on models of integration, barriers and facilitators, as well as best practice. And we interviewed 15 professionals and 10 experts by experience to understand their views on what a kind of gold standard model of integration would look like. And we had a wonderful roundtable with lots of people in this room who came, so thank you. So what people told us was the problem. I've tried to illustrate with this spaghetti junction. It's really a super fragmented system. Perinatal is unusual in many ways. Often how mental health and physical health interface is difficult. But perinatal has so many different interfaces. So, between maternity and health visiting, between maternity and family hubs or children's centres or local authority, between mental health services, between the secondary care and NHS talking therapies, which is our primary care mental health services. All of these are often commissioned differently, have different data management systems, have different thresholds, but we also have different areas have different things. So the same NHS talking therapy in one area will have a different threshold and skill set to another one. So there is incredible fragmentation. As a professional, if you can't understand where to send people, and I hear that all the time from midwives, from GPs, they never accept my referral, so I don't bother anymore. I don't know where I'm supposed to go. And if they don't know how it works, how are women and birthing people supposed to know how it works? You kind of pluck up the courage to say, I need help, and then you get passed around. You have to repeat your story. You're told, no, you're not ill enough for this service. You're too ill for this service. You experienced something that particularly one of the things that we found in our study was that perinatal loss, mental health difficulties following perinatal loss, was a big gap. So people were told that they didn't experience their loss at the right time or in the right service. And that, again, was, a reason to be passed around. That's so disenfranchising. So, of course, you don't want to keep going with that. And you fall through the gaps. And this is what we found. This is what people told us again. And professionals find it too. They are also struggling with this system. It's not set up to be integrated. And we also found that for these common mild to moderate mental health difficulties, you'll see me stumble over the language, but that's the language we have, that although we do have some promising examples of which we illustrate in our report, so please do go and read it, of NHS talking therapies doing beautiful perinatal pathways, we actually just see most of them not. And that work to be perinatal specific, to be able to accommodate a baby, be flexible in your timings, to really understand what it is to go through a traumatic birth and what maternity services look like, or to have a phobia of birth. Those things require specialist perinatal expertise. They often require joint working with maternity colleagues. And that can't happen if you don't have that integration and that training. And of course, it's a heavy thing to keep finding, but we know that it is the marginalised groups that are particularly falling through the gaps again and again. So, in fact, all women are falling through the gaps, but it is those marginalised groups that are falling through. Guys, can we I'm doing great because there are a lot of things happening. Okay, I'm going to go through because I'm sure we're a bit behind. These are all the papers that we found. And what we found in our scoping review was that essentially what we've done the most research on is actually integration of practice. So what we were really interested in is how can we get systems and services integrating to come together? And what we are finding is that you can train someone up to perhaps be more psychologically minded if they're working in a universal service. Or similarly, you can train somebody up in a mental health service to be more perinatally minded. And, universal screening, one of the things that Annette mentioned, is one of our success stories. But that is really integration of practice that isn't bringing systems and services together. And people often spoke about integration interchangeably between these two things. So we were really trying to get to integration of services, where they had things like, a kind of central point of access or a central referral, where there was joint commissioning, where there were kind of joint boards across the system, where mental health professionals or health psychology professionals were embedded in the acute or universal services. How did that work and how could we learn from that? And we also wanted to understand, it seems like a good idea in principle, but does this benefit and how can we enable that? What facilitates this process? So the benefits are huge, both from the bits that we found in the research, but also from what we were hearing in those small examples of best practice. So for parents, they were telling us that when there was integration, that services became more accessible, but it hugely reduced stigma. The idea of having this process of being referred to someone outside in a different system that you didn't know was hugely reduced when that was joined up, when you could say, oh, actually, my colleague Sophie from down the hall can come in and have a chat to you about that. This is what we do. We offer this to lots of parents. It's normalised and it's joined up. And then you see this hugely improved identification of difficulties. You've seen this in the survey that Angela presented, but we've got about 70% of people who will underreport their mental health difficulties. It's huge. We see that more marked in marginalised communities who are facing other kinds of discrimination and marginalisation. And it's really difficult to talk about that. And so when people do, and when we give them the space and the skills to do that, we need to then have the follow-up there immediately and appropriately in the least stigmatising way possible. And this is particularly true. We took a real lens on trying to understand how this work could work, particularly for racially marginalised communities. And I mean, I could speak for my whole 10 minutes, of which I'm probably run out of time with all the ups and downs about this specifically. So please read the report to understand what we found about this. But I mean, most things that work to improve access for our most marginalised women and birthing people is what works for all women, and so should just be good practice. But co-production is absolutely at the centre of that. We need to understand how to integrate that works for women locally based on their needs. We see huge benefits for professionals though. So this, you know, the idea that this is kind of economically what we need to do is absolutely true. Huge improvements in efficiency, all of that going to the GP, coming back, having a referral, speaking to this person, being triaged in talking therapies, and being triaged in the mental health service. All of that can be removed if things are integrated. But we see a staff that are feeling less burnt out, less stressed, more confident, more empowered. Here they are. How am I doing for time?
As quick as you can. How is that helpful?
So, what should I want to say? One of the things I want to talk about is data. So data is probably one of the biggest barriers, data and IT and integration. And it's not really a sexy topic, but it's so important. And so we really need to get a handle on it. And we saw some really good examples of how that work can be done beautifully for systems. And so one of the things I would say that helps with this, you know, that spaghetti junction of perinatal is how we can disaggregate data better. We need to do a much better job in displaying our data. So who are the perinatal people, or the parents even? How often do we ask, are you a parent when someone goes into secondary care mental health? Who are those people? We need to record them. And similarly, who are the people with mental health difficulties in the acute services? We need to normalise those things, and we need to report them. And we need to report on protected characteristics so we can understand who is accessing our services and who isn't. And that is really important as well. And particularly in CAMS, can we please say who are the babies so we know what babies are being supported in CAMS? We just don't have that data, and it's so important. When we see, you know, when this really works, it's when there's this kind of shared, we talk a lot about shared perinatal mindset. It's one of our competencies in the UK. But what this means is that we have a language for thinking about perinatal mental health that's shared across the system. And that can be in terms of the measures we use, the pathways we have, the thresholds we have, but it needs to be shared, and it needs to be everybody on board, particularly with the onset of the wonderful Family Hubs policy. But where we saw great examples of best practice we illustrate in the report, it's where we have public health specialists from the local authority and family hubs leads on the same board in the ICB as the maternity commissioners and the mental health commissioners. They need to work together. That's why that whole system was set up, and it isn't happening. And that's what will change. They need to kind of have this shared strategy for perinatal. And so I will finish, because they're getting a bit itchy, by saying that what we are proposing in our report is one perinatal mental health service, so that there's one front door, or there's no wrong front door, I think is possibly a better idea. And that there is a team that comes together across a system from mild levels of need all the way up to the most severe to support women and birthing people, families and babies to come into a system. And to do that, at the moment, we need a dedicated psychological workforce for the mild to moderate mental health difficulties. And this may be a new workforce. It may be that we can use some of the Family Hubs workforce, some of the NHS Talking Therapies workforce to create it, but they need to be dedicated and ring-fenced to this population that is at the moment falling through those gaps. And to do that, we have done some workforce modelling to say that we need 9.5 full-time psychological practitioners for every 10,000 births in the country. And all of our assumptions for that are in the appendix, so you can see it. But so that works out just over 500 new psychological practitioners in England, which actually I think sounds like a great deal. if you saw the millions and billions that Annette was showing us, to really support the people that need it most before they escalate to having those severe difficulties. So this is something that I would love to see come out of Baroness Amos's review, and is something that I think the system and mums and babies and their families need.
Thank you very much. And yes, a shame about the hiccup at the beginning, but you took it off beautifully. Thanks very much, Alex. I knew you had to leave us. Thanks for coming. So we're going to make a slight jump in the programme because of timing and because we have the wonderful Anna Whitehouse with us, who has damaged her foot, and is having to leave a little bit early because of
the school run.
Childcare. And so we're gonna get the panel underway straight away and come back to some comments from a diverse range. So could we have our four panelists sitting here to give us some comment into these microphones? And we have Anna Whitehouse, a journalist and broadcaster, who was on crutches but is managing to walk now. Yes. So Anna Whitehouse, journalist and broadcaster and founder of Mother Pucker. I think I've got it right.
Yep.
And who is going to give us that broader perspective. We focused on the mental consequences and getting in there early at the beginning of motherhood. But there is, of course, from the Make Mothers Matter survey, this whole issue of the rest of motherhood as well. So the support can't just stop after the first year or two, and the support from the system and our society. So I'm hoping you will inject a little bit of that story into this conversation. And then we have Chrissy Brown, who is somebody who speaks amazingly from her lived experience, being able to take that experience and turn it into statements that are inspiring, I think is a really extraordinary feat, and we look forward to hearing from you. And we have Alison Morton, who's the CEO of the Institute of Health Visitors, and we've talked about integrating a complete mental health service into maternity care. But while we've been doing that, all of us are conscious that we're actually talking about it being across the whole of universal services into early childhood services. So we look forward to hearing your take on that, Alison. And then we have Andy Bell, who comes from the CEO for the Centre for Mental Health, to give us the kind of pure mental health perspective from the world of mental health on these issues. And what I'd like to ask all of you is, is this, in this world where there are so many things going on, so many horrific stories, so many demands on our politicians, is this really that important compared to all of those other things going on in the world? So I'd like your views on that. And secondly, if it is important, is it something we can do anything about? And thirdly, if you think either of the answers to either of those are yes, when? So maybe Anna, could you kick us off?
Hi, so yes, I'm Anna Whitehouse, the founder of Mother Pucker, which I have to be very careful how I say on air, which landed in a very maternal, raw, visceral place, which I'm sure many parents in this room can understand, where I was running late for picking up my daughter from nursery. And I had apologised to pretty much every single person in the 2 hours prior to picking up that little girl with watery Bambi eyes, wondering why her mummy wasn't there with a Paw Patrol backpack on. I'd apologised to my boss at 4:59 p.m. I'm so sorry, I have to leave this meeting. I then apologised for squeezing onto an underground tube. I'm so sorry, I have to get to nursery. I got to nursery. I'm so sorry I'm late. And I was charged £1 a minute after 6. I'm so sorry. Here's my money. And then I got to my daughter and I said, I'm so sorry. And I remember thinking, I don't think I can raise her to apologise for something that is not her fault. So that was 10 years ago. And that was when I stopped saying sorry, because it's not my fault. And you ask me, with all the facts, the figures, the stats, the research, everything you see here, what I deal with on a daily basis, you see the iceberg of one tired mum. And what I get on a daily basis is the living, breathing, brutal reality of what you are saying here. The mothers who don't know where to go. I'm desperately, as not a doctor, I'm just a journalist, an exhausted mum, desperately trying to pay the mortgage and not burn out. I am acting as some bizarre kind of signpost to women who are drowning in the system. And if you ask me, is this an issue? It's seismic, it's fundamental. Like having a baby is Mother Nature's biggest task, and yet we're made to feel like the lowest citizens. And so all I'm going to say, just from an emotive point before we carry on, is of course it is the most seismic thing, but I am part of that generation of absolutely burnt out, tapped out, financially drained women who were raised to want it all. All is not good. You don't feel good after an all-you-can-eat buffet. All is not what we want. But do you know what? We're doing it all. And so I'm so grateful, and I wanted to say this from a very heartfelt maternal place, that there are people gathering in rooms like this, that there are people who care enough to find the numbers and the facts and the figures to give a voice to that underbelly of motherhood that is completely being lost. So yes, a resounding yes, for me and my daughter.
Thank you. Thank you.
Let's see, can we move to you? And,
Yes.
tap into your rich experience.
Yes, so my name is Christy Brown, founder of the Motivational Mums Club. Motivational Mums Club was born out of pure joy, and that's something that I do not shy away from. It was born from a good birthing experience from my firstborn. And I was completely oblivious to mental health difficulties because I was on cloud nine after having a great birthing experience and walking out the door, getting a promotion, being in the investment banking industry. So those stats there really resonates with me because after I found out I was expecting my second-born, my mental health deteriorated and I didn't even know what the signs even looked like. So I was going through it, I was living it, but I didn't understand that, yes, that's basically the root of difficult mental health where it was born. Fast forward, I was, sent home 4 times with my daughter, which led to a very traumatic birth and contributed to the mental health difficulties that I was experiencing at the beginning, which I was completely oblivious to. And I would simply just cry just because the sky was blue and having intrusive thoughts. And when I did actually reach out to my family about it, I was told to pray about it. I should be, trigger warning, be grateful to have children. People are not lucky enough to even have one. So automatically I've tuned out, wait, hold on, that's right. And that led to me resigning and making that very difficult decision of leaving the investment banking industry and losing my identity. And that's when Motivational Mums Club was reborn, to really focus on sharing my lived experiences and helping others, to get the support that they rightly need. And to answer the question in regards to, is this important? I don't even know why it is even a question. Absolutely, yes, it is important. And I've been doing this for years now. I've sat around in policy making tables, commissioning tables, and I can't help but see a pattern. When mental health is actually at the forefront of someone's most difficult thing to manage, it impacts on their physical health. So why is this not actually a priority on these main big tables? Because it's leading to other complications. And I'm no clinician, but I see it happening, being on the ground and serving the mums that are actually going through really bad mental health difficulties. But then I do it also in collaboration with the NHS, local NHS trusts that is now in 7 boroughs. So if you ask me, yes, it's not even a question. It should be absolutely core to what we should be doing in this country and in Europe, because we're raising the next generation, right? And if a mother is experiencing bad mental health care, how do you expect the next generation, the children, to flourish in the right way that they're meant to, considering everything else that we are battling in, which is, you know, the economy is drowning, number one, but then how do we actually allow these moms to function and support and bring up these children in a meaningful way?
Thank you very much. Alison.
Yeah, so no surprise, 100%. Of course, it's a priority. You know, we're building the future generation for our nation, and it's the women's job, burden people's role to do that. There can be no bigger role in society. I did the COVID pandemic back in October, and I said we spend billions on building bridges and roads, but not on our human infrastructure. The people that will make the society we're passing the baton on to. And actually, this matters not just for women, it matters for men. Got some advocates for men's health during the perinatal period here too today. It matters for children because fundamentally we know the massive impact it has on children's well-being in the long term. It has economic benefits, we've heard from Annette and many others in that space. So 100% it has to be a priority. So for health visitors, we are in a hugely privileged role. So we go up the dusty farm track behind the front door on a high street where you don't know anybody lives, and we see the families crumpled in despair, and they don't know where to turn. In some pockets of England, there's some good services out there, and you alluded to those, and we celebrate those, and we want to drive excellence with excellence, but far too many are missing out. And actually, the health visitors often have to take the flak. They have to tell the family, I'm sorry, there's no support. I'm sorry, I can't help you. I've got a case of 1,000 babies, and I've been told, we just haven't got capacity to pick it up. And that is literally heartbreaking. And health visitors watching here today, we're banging that drum, fighting for investment back in health visiting in England. It's not the same across the other UK nations, they're better equipped. We see across the globe, there's evidence across the globe of the impact of health visiting. And I guess the biggest, we call it the USP of health visiting, is the reach range response. To reach every family, which is so important. It doesn't matter how brilliant your interventions are, if we don't get to the places of the women who need it and broker that engagement. And that's the hardest bit. People aren't queuing up saying, I'd really like to join your group, thanks. I'd love to go to your therapy. They really aren't. You know, they need somebody to say, this is something you can trust. Honestly, there's a light at the end of this tunnel. You know, you can get better. And to give them that hope, and that's the role of the health visitors to do that. The range of skills you need for that, people are complex, they're in a complex world. They have multiple issues. It's not just perinatal mental health, they might be struggling with poverty, mouldy homes, the whole raft of things. So we need that. And then the response, it has to be integrated. So it's not just health visiting, psychological therapy, women's support. We need the whole raft integrated across the system, and it needs to be fully funded. You know, we can't run it on fresh air. You know, money has to come behind the rhetoric. Rhetoric's coming, which is positive, so we thank the government for it. You know, but we want to hold their feet to the fire to deliver on this one.
So just looking at my second question, which is, can we do something about it? You're saying that there are places where something is being done about it. There are some models for working much better in this area. Would what Camilla was suggesting, having therapists within universal services connected to the whole rest of the perinatal mental health system, would that be welcome from health visitors? Would that help?
Well, I think it's there's no one size fits all, isn't there? There's no magic bullet. And I think different things will work for different people. And so the model is, whether it's the specialist health visitor trained up in that role, or you bring somebody in, you know, fundamentally, as long as it works, you know, as long as I'm going to fight the corner of health visitors, because there is some really good work being done by specialist health visitors out there who've been trained in infant mental health, in women's mental health, fathers' mental health, you know, the whole family approach, whole people, often there's physical health problems as well. So there are benefits in that respect, but equally having somebody focused on the perinatal psychological therapies, we've seen benefits from that too. So, you know, both great. Yeah, let's get support in front of these women.
Great, thank you very much. Andrew, your thoughts from the world of mental health, which is struggling with old age, adults, adolescents, everything. Is this important? And can we do something about it to make things better in this area?
It'd be strange if I said it didn't matter, wouldn't it? Thank you for the chance to be here today. At Centre for Mental Health, we're an independent charity, and what we really care about is reducing inequalities in mental health and tackling the injustices that create so much mental distress and the inequities across our mental health system. So for us, this really matters because we know there are huge inequalities affecting women. It's extraordinary, isn't it, that in the latest psychiatric morbidity survey, the figures came out that young women are twice as likely as young men to experience common mental health problems. How much have you seen that talked about since? That came out in June last year, and that is an extraordinary inequality in mental health, and we simply do nothing about it. So I think there's some really interesting questions there about actually how are we going to tackle these fundamental inequalities. We've been very lucky at the centre. We've worked with Annette on the 2 economic studies that she's presented. We've worked with the motherhood group to understand the experiences of Black women. We've worked with the Maternal Mental Health Alliance to look at the experiences of young mums and birthing people. The picture is consistent. That mums and birthing people are not being offered the right support, that there's not the right opportunities to disclose difficulty, and therefore opportunities being missed to provide the right kind of healthcare quickly when it's needed. I do think we need to move away from these words mild and moderate. We know what they mean, and in clinical terms we understand them, but they are prey to that discourse that says, oh, you know, mental health problems are just life's ups and downs and we all just need to get with the programme. We need to challenge that and actually say common mental health problems are incredibly serious, and yes, a lot of people experience them, but they're really important and we do have to tackle them, and if we do not tackle them, we know the consequences. And we know the consequences are severe. I guess a couple of things that maybe need to be said. The first is the importance of supporting women and birthing people who experience baby loss with specialist support. We know that's fundamentally important and still not being valued sufficiently around the country. That's scandalous. We know about the importance of support in early years. You'll be excited to know next week we'll be publishing a report about parent-infant teams with some economic evidence which looks pretty good. There's your trailer. Keep a look at our website next week, it will be there. And then I think a really simple point, which perhaps we need to make because it's so obvious, is it's better to prevent mental health problems than to have to deal with them. And the way to do that is not to try to make people mentally healthier, though that's good. It's to change society, to give people a better chance of good mental health. So we need to tackle the misogyny, we need to tackle the workplace inequity, we need to tackle the racism that is leading to these problems in the first place. And until government is prepared to have a whole government approach to mental health and really tackle things systemically, we're going to be dealing with the pieces in people's lives which have been shattered needlessly by things that could be put right much better.
Thank you very much. Because time is short, I'm actually going to stop there. And I know, Anna, that you had to go off for your childcare reasons. So I'm going to thank the whole of the panel. If we have time still, we will come back to questions, but we'll come back to you in your seats. So thank you again very much. So, thank you to our panel for considering these issues from those perspectives, those really valuable perspectives. And we do have a number of other people in the audience who are given, I've said I will give 1 to 2 minutes to, and I'm going to give them 1 minute now because we're so short of time because of the various technical, and have we solved the latest techniques? Oh, we have, right, okay. You don't even know about that one, so I won't tell you. Well, pretend there wasn't one, but there was another one. So I'm going to come to Clea. So yes, Clea from the Stillbirth and Neonatal Death Society. You've heard these issues mentioned a number of times, but there are particular issues around loss at the very beginning, or rather the beginning and the end of motherhood, with at least that particular occasion, and the psychological needs around that. And would integration of psychological and physical healthcare all in one help with that, or would that be a challenge?
Thank you very much indeed. Yes, so we are here for all pregnancy loss and baby death. And I think what's really sad, obviously unmet need that we've talked about, and the stigma of mental health, but actually within that, the biggest stigma is pregnancy loss and baby death. So the biggest stigma is baby death, pregnancy loss. We know 50% of the population are either directly affected or someone close to them is. And yet, we've heard it mentioned twice, and yet the mental health issues experienced by bereaved parents are extreme. We know from our Lost in the System report, 81% want more help with mental health issues, yet they are invisible. And with an integrated universal system, unless the specific needs of those suffering mental health issues after a pregnancy loss and baby death are addressed, then it will be failing this hidden cohort of women and families. So I welcome the opportunity to critically scrutinise what is happening, but I do think unless specific training, specific thought is given for these families, that actually it will just compound the issue. They will remain hidden. Only 50% could access any of the support and only 17% on the NHS. For many of them, the fact that they don't have a baby means they are excluded, and anybody who's suffered a pre-24-week loss is excluded anyway. And so I know many of you in this room will probably have personal experience given those figures. It is not acceptable, and an integrated system must take these needs into account. He's coming closer.
Thank you very much. It's complex, isn't it? And so many things to think about, but we've got to do it. Simon Ofer is an MP and has given of his time, dashed over from Parliament to be with us today. So thank you, Simon. I'm going to give you just a minute or two just to say a couple of things.
Great. I'm going to stand up. I'm actually properly a GP. I've been a GP 30 years. I've been MP about a year. But just to put that in context, a few quick things. I've done loads of postnatal GP checks. If we leave the GP to do any sort of screening, it will become a tick box exercise like, are you all right? Fine, on. Do you know what I mean? So I think we have to have an integrated system, but I think we need the right person to do the screening. And I think we desperately need screening, probably earlier than 8 weeks, actually, to see what's going on. And I think that does go on, and health visitors are doing a fantastic job, but we need to make sure that's universal and there's no gaps in that. So that's one thing I would say. The second thing is around the treatment. And I think what I worry about is that we're going to put lots of people on antidepressants, and I think we really must fight against that and use much more community-based supports. There's some great evidence around getting women who are depressed singing and that sort of thing. Let's use lots of diverse ways of getting people better, not antidepressants. And I think sometimes people will need antidepressants, but not that many of them. So that's what I'd say. And then the last thing, I promise to be short, is integration depends on sharing data. Now, our health visitors write in System 1, which is the same one. That's all right. But if they go to mental health, they have this Rio system or something. We can't see that. They can't see our things. So we must share that data. And GDPR is a real pain in the arse, I think. And we've got to share all that. So that's all I'd say. I think we need a screening test, which is probably properly funded, because that will prevent women getting undetected, and it will actually make women better as well. So thank you. I'm really sorry I've got to dash off now, but that's my life. So thank you very much.
Very much, Simon, and thank you for your support always for this cause. So I'm going to move on to Livia from the Royal College of Psychiatrists. And Livia, I know that there's been this huge investment and expansion in perinatal services, specialists for very high-risk women, but they are being overwhelmed with requests for women who don't need such complex, expensive multidisciplinary care, and would better care for that group help the specialist services to deliver better? and are they ready to support other services?
Thanks. Thanks, everyone. So all the good points have already been made by somebody else. But in short, the answer is yes, I think. Talking about a common mental illness is like talking about diet control diabetes. It's going to be diet control until it's not. So it's really important to make sure that these things are intervened on in early stages. And sometimes they can be even managed and stopped at their very onset, not necessarily by something that's specifically psychologically or psychiatrically informed, but by strong and consistent mainstream communication. So in my experience and from what I've seen, it's not uncommon that people will get very inconsistent messages that can be very anxiety provoking in early postnatal stages during pregnancy, all because of very well-meaning clinicians that want to inform, but the end result can be actually stressful. And starting from building a system of communication that works might be a first point. What I would say is that actually what the way that I see this as something potentially transformative is thinking of it as a model for the community where it's not just about maternity and health visiting, but it can include GPs, it can include nurseries, schools, and be family-centered with connections to the specialist inpatient antenatal, postnatal wards and the obstetricians and all of that, and also, of course, perinatal and more specialist psychological teams like the ones that now exist as maternal mental health services. Who knows? Who knows? But that I think that's where the work, and I know that the college is putting this as one of their objectives as well.
So that complex motorway needs to be simplified and brought together and linked up.
And linked up.
Thank you so much. And now I'm going to, so who have I got next on my list? I've got Alison Wright, who is sitting at the back there. So we've Alison Wright from the RCOG. Wonderful to have you here. I'm going to pass the microphone just for those people listening at home. But it would be great to hear from you. What the obstetricians, and I know maternity services are overwhelmed with what they're doing already. Are we just going to overload you with yet more things that you really don't want to know about? Or is this something that we've just got to find a way to do?
Thanks, Alan. Yeah, and absolutely, it's their way, and we will definitely find a way to do it. Just say credit to Alan, really, for your amazing tenacity in keeping us all towards this common goal over the years, Alan. Thank you. Latest Embrace data, we all know that 1/3 of all maternal deaths are linked to mental health. 1/3 is massive. We all know that suicide still is the leading cause of death for women between 6 weeks and 1 year postnatally. I'm delighted to see Elizabeth always flying the flag for postnatal women. But this is really shocking data, and an absolute call to action. And as Shanaz said earlier, these numbers are real women, real families, real communities that are suffering. So one of my, I'm only new in post, by the way, one of my key pillars as president of the college is to make sure we do collaboration well. And I don't need to tell anyone in this room why it's really important to collaborate between mental health services and maternity services. But I think we all do need to tell people outside this room that that is really important, because I think people don't always get it. And certainly looking at maternal deaths from psychiatric causes, it's not a failure of those services nor maternity services, but I think it's a failure of us all in not integrating those services. And I'm really pleased the word integrate has come across loud and clear, and we're all absolutely committed to that. I think it's fair to say that obstetricians have not always been at the table when it comes to perinatal mental health. There are lots of reasons for that we can talk about if we have time, but we are absolutely committed to changing that anyway. So we have a real opportunity. So both myself as a new president, one of my new vice presidents work in perinatal mental health in our day jobs. So we've got a great opportunity on behalf of the RCOG to take collaboration to the next level, including women, as Claire said, very importantly, who have had pregnancy losses. So I think it's clear from everything that we're saying today, Alan, that only by working together as professionals and living to those with lived experience, that we can really give the care that women deserve. So yeah, looking forward to next steps. Thank you.
Fantastic. Thank you very much. Thank you. We've talked a little bit about fathers, but not as much as we should do, partly because the remit of these various reports has been on motherhood and mothers. But it's a huge pleasure to have, well, we have two representatives from fathers in this whole room, although I think everybody in a way represents fathers. But Adrian, I'm going to give you the floor for one or two, absolute maximum two. But
I'll be very brief. Thank you very much. Right, so I'm Adrian Burgess from the Fatherhood Institute. When Alan was setting up the MOHA, we had a long talk about fathers, and I really understood well why in the end they didn't push to do fathers alongside mothers, because if we'd asked for too much, the government would have put it in the too difficult box and would have done nothing. So it is step by step. But I just want to bring one stat. First, I want to bring a few statistics to you. Firstly, 95% of parents are in a couple relationship at the time of the birth. 95%, 95.4% of fathers in the UK, in England, sign the baby's birth certificate, jointly read. There are hardly any single mothers at the time of the birth. The dad is there, right? That's the first thing. And then the other thing I want to say is that Alan knows about this as well. Swansea University did a study of maternal suicide in the 1001 critical days. But they did another thing. They actually added in, they looked at the father's statistics. And what they found that was across the 19-year period from 2002 to 2021, let me just check this for right. Yes, 16 mothers in Wales committed suicide, 107 fathers. So the fathers are 7 times more likely to kill themselves in the 1001 critical days. We can't let this go, because as anyone knows who's had anything to do with suicide in the family, the shadow that casts goes on for generations. Thank you very much.
Short and to the point. I'd like to say short and sweet, but in a way not so sweet, is it?
No.
And thank you for that really important reminder. And why shouldn't dads be involved in any integrated care? In fact, how can they possibly not?
Exactly.
And other partners as well. Yes, thank you so much for that. So you can see we're building the complexity of what we have to achieve, but we started with, we've got to do this, and we know why we've got to do this. So I'm now going to turn to Hannah Leonard from the Royal College of Midwives. Now, which microphone is switched on? This one? Yes. So please give us the take from hard-pressed midwives who are desperately short of staff, just as we heard from Alison with health visitors. Can you possibly cope with us piling on yet another issue and responsibility? Or is it something you already know is there?
Thank you, Alan. Thank you, everybody. As midwives, I think we've been on this journey with mental health services from the very beginning. We were with women before the services were established, and actually it's nice to take a moment as we sit here, having been part of maternity services for a long time, over the past decade, about how different they look, actually. And while it is a hard journey, we should celebrate some of that movement forward, and particularly testimony to Alan, who's been spearheading the way for a long time in that. As a result of that, we now have perinatal mental health much higher on the agenda. We have many more perinatal mental health midwives, which is fantastic. We have an improved access rate, I believe around 10 to 13% it might be of women in England now can access mental health services that were almost non-existent 10, 12 years ago. Mother and baby units across, talking between professionals has massively improved. That is not to say that the challenge is still not very present and much more work is needed. We've had the CQC maternity survey, and I just want to take a moment because actually, as much as we look at the problem, actually we need to look at how well and how far we have come. And the latest survey in 2025 showed that 90% of women had been offered mental health support in their pregnancy compared to 83% 5 years ago. Small wins, but big movements forward. And that's testimony to everybody in this room working together to deliver that. However, we're at a difficult time in midwifery. We have had an increasing number of policy demands, and perinatal mental health is just as important as many of those others. We are struggling with our staffing, and as a result of that, that has a huge impact in us being able to deliver things like continuity of carer. Increasingly, women and families are seeing different midwives at each appointment because of the services that we're being stretched to provide, and we know that that impacts on people on families, on women feeling confident to be able to have those conversations with their midwives, to be able to disclose, because there's still a significant stigma around mental health and associations with concerns around safeguarding and the underpinning reasons for that. And if you layer on top of that cultural complexities in some of those conversations, it becomes increasingly difficult. Then there's the time for referrals, follow-up for referrals, the issues with digital systems, but we must get it right. We must make that more seamless in the things that we do. Not just in terms of the time for staff to listen, the time to staff to care for these women and support them on a very vulnerable time. At a time when media is making that even more difficult, there's higher amounts of fear that it's much more prevalent to women around the impacts of pregnancy, birth, and their journey that they will go on. And I just want to take a moment to say that some of these things remain, from the assessments we talked about getting it right, but how we have those conversations, to the referral pathways, to the training. Those things are still very topical issues about how we do that. And if there are ways that we can do those things together to make sure that they're seamless journeys. So we're not asking the same questions to a midwife, to a GP, to a health physicist. The woman doesn't have to relive that all the time and get a slightly different nuance in it. For everything that we can do about making those points more seamless and deliver that care for women, I think that that's a really important step in our journey, on our ongoing journey, for the many celebrations and successes we've had so far, but for the next steps.
Thank you so much, Hannah. Really rich perspectives on the realities on the ground there. And I'm going to come for our last comment to Nikki Wilson, who's at the back here, who's CEO of the Maternal Mental Health Alliance, so to which many of the organisation here are members. And I think you've got a little positive message announcement to make as well, which is really nice news.
Thank you, Alan. Really interesting to listen to that mixture of people raising their concerns, flagging the complexities, and equally being invigorated by the potential solutions that are around. So since our inception at MMHA, we have been passionate, led by Alan's passion, as you've all felt today, about perinatal mental health care for all mothers, birthing people, and their babies and families, and about how we can affect that change across the whole system. So it is systems changing, visionary stuff. We started with advocacy, much more focused around specialist perinatal mental health services for a multitude of reasons. And yes, there are challenges, and we do have to fight to protect the progress that's been made, but particularly relative to the rest of the world, huge progress has been made. We are generally known to be the world leading country for perinatal mental health care and provision. So hold on to that as you leave the room today. But of course, there's much, much more work to be done. There always is. There is unanimous, and widespread concern about this challenge that we have with 100,000 people or more who are not receiving the support and care they need. And if you load in the dads into that, you're looking at a lot more than 100,000 as well. essentially integration is great, but if you go back to the WHO data that sits under this, it says in their reports, effective integration into existing, that's not it. Effective integration cannot and will not compensate for under-resourced systems. We have to fight. And arguably, we have to fight harder than we ever have done to keep perinatal mental health on the map, to keep it a concern within our government. We are fighting in every which way possible, just looking at Karen, because she and I are often sitting in all the multitude of advisory groups where we're desperately keeping perinatal mental health on the map. But we just want to invite you to carry on fighting with us. We have so many opportunities for change. Alan was referring to, after much kind of lobbying, we now have a specific perinatal mental health roundtable for Baroness Amos at the end of February, looking at how we can influence more and again the importance of perinatal mental health in the maternity and neonatal investigation. That's one of many angles within which we're trying to influence change and really, really trying to change national systems. So to all of our members who are with us today, hello, thank you. If you've not heard of us, join us, the Maternal Mental Health Alliance, reach out, contact us. And, we are on the solutions focused side of things. We're campaigners at heart. So let's just keep fighting to fix things as best we can. Thank you.
Thank you very much, Nikki. And that concludes our kind of comments from a variety of angles. But we actually want to throw this discussion open to the floor, both the floor physically and the floor virtually out there. So, Shanaz, we have a hand up straight away in the room, and then you've got some. Well, I'll go with this one.
Can you go with that one, and then I'll.
So, questions for both each other and our panel and those who've given comment or comments.
Thank you very much. My name's Rebecca Chilvers. I'm here on behalf of Neoleap and the over 200 psychological professionals working in neonatal care and paediatric intensive care in the UK. And my point is twofold. One is we have over 90,000 babies. That's 1 in 7 of all births that would spend some time in neonatal care. That's 180,000 parents a year. And I feel obviously strongly advocating for the needs of those families. We know that the mental health needs of those parents are several-fold higher than even our perinatal population, and that those children go on to have a number of consequences. So our approach is in theme with being integrated in that we work with the family as the patients, and we work with mothers and birthing people and their partners and their wider families. So I suppose I just wanted to put out a plea to everyone here, and when we think about integrating, to think about the importance of attending to that very vulnerable population in our thinking and policy. Thank you.
Thank you very much.
We've only got the one mic.
Hello, Julianne Butler, perinatal psychologist. I'm going to bring anger to the room. I'm sorry. I feel angry and frustrated that after 26 years, we're still talking about the same things. I'm sorry. I feel we will only move forward if we actually feel the outrage that we should be feeling about the fact that 42% of women birthing people in this country are basically having to have medical treatment to give birth. We have to sound the clarion call of the fact, and I'm really sorry to say this, that systems are not working. And I think it's really good, and I'm really, really mindful that everybody here will have a different perspective, but we are letting people down if we do not summon and use our outrage and our anger about the state of different parts of the system. And there are many of us in this room who have lived memory of how it was different. I know I do. And we cannot let go of that. We cannot forget that. We have to hold on to our lived memory and experience to say it's getting worse, not better. And we have to, I think, really impress upon those with power what the long-term consequences are for the family, for the family, mothers, parents, babies, children. Sorry if that's been uncomfortable, but I've been sitting on it for the last half hour and feel I have to say
Very
it.
courageous. Thank you very much indeed. We have got some questions coming in from the online audience, but we've got question there. So I'll come to you. And Fennel from Mothers at Home Matter.
Thank you very much. I've got a bit of a cold, so I'll try and speak through it. Two things just come to mind. Totally recognise a lot of the problems. I think underlying it is why are we having so much ill health? I think one of it is narrative around raising children. There just doesn't seem to be the appreciation of raising children and what it is for society, and therefore there's a lack of support and a lack of policy. And the second is the economics, because for us anyway, very few people can make the choice to be there for an intensive period of time, but there's no support for that either. Even amongst partners, amongst the government, it is very much a labour policy to get women back into work. But really, I think underlying it all is just that there's no recognition that it's actually useful work, and that children need this intensive, loving constancy of caregiving. So somehow we need to change that, and then maybe the support will come. But also somehow we can free families to make the choice that they need to make, and I think that's an economic thing. That will be in housing. That will be maybe reducing their tax burden. Somehow we've got to sort of have that whole holistic picture.
So not just all the organisations and people represented around this room, but the whole of every part of government and indeed society. Can we do it? We have to.
Your panel said we have to. And now, did you have a question?
Hi, Elizabeth Penny, consultant clinical psychologist from Birmingham. Really linking into what some of these speakers have already bravely mentioned. There's a bit of an elephant in the room in the destruction, really, of our kind of society. And what I'm seeing in Birmingham is massive deprivation. Women and society in general really, really struggling. And these difficulties can't be isolated as mental health, because when they are, it's really only the privileged who understand the language of mental health who access services. And I'm proud of the service we provide in Birmingham, and we are able to provide it for many women and really be life-changing, but it's not enough, because the whole of the culture is suffering from, people mentioned it, from misogyny, from racism, from deprivation. And so we have to be a campaigning organisation. We have to lift our voices and say it's not good enough. And women shouldn't feel they have to say sorry for being a mum. This is hard if you're privileged, and it's much harder if you're poor and if you're minoritised. So it's that practical work is really important. And I just very quickly, and then at the beginning you mentioned that relationships get us through and that practical support gets us through. And I'm a psychologist, so I love psychological intervention, but you're right. We need to fund and ensure there's access to relationship support and practical support. So there's a culture that says you need care and you deserve it.
Very much indeed. I just have to say that we're getting some messages coming in that people online can't see these wonderful questions and wonderful commentary. So apologies, because the camera is facing forwards and not this way. So LSE will have to change a few things. The next time we're here, we'd like a camera there, and there. I've got a question here from Afaf Abu Nwada, the Chief Executive of Make Mothers.
Actually, it's not a question, but it's answering to everything that we've heard today, and answering to you actually about campaigning. Make Mothers Matter is exactly what I mean, that's exactly what we do at Make Mothers Matter. It's not really campaigning, but it's fighting, and it's bringing light and shedding light into all the challenges that mothers face, whether in mental health or in their life, career. Work in the workplaces, the motherhood penalty, what we call the motherhood penalty, also in the work-life balance, as we have seen and said. So all these topics are at exactly what we fight for every day at the UN, at the EU, at the European Union, at UNESCO, including also education. But we have not forgotten mothers. I mean, it's the core. It's what we. I'm trying with English, but it's at the core of what we do, and it has a lot of meaning, of course, because as we said, we are the voices, yes, of those who don't have a voice. So please follow us, support us, visit our website, see everything we do, and let's do that all together. Thank you.
Yeah, it would have been easier in French. Okay, we've got a question that I will just, 1 second, Alain. I've got quite a few. Yes, Camilla.
Thank you. I just wanted to briefly respond in part to what Clea said earlier, which really resonated with me and was a big part of what went into the report and the workplace modelling, which is essentially how invisible women and other people who've experienced loss can be in this space. And the stats that you shared were really compelling. I think one of the things about that we can change is, again, back to data. Where loss is recorded in our system is in so many different places that you have to work really hard and intentionally to bring that in. And when we think about perinatal mental health, we always fall back on prevalence based on birth rates, and lots of people that experience loss are invisible from those stats. And so when we've modelled our services before, they just have completely discounted them, which is a huge shame. And it means that therefore all of our workforce members can't meet their mental health needs, which are significant, as you highlighted. And in this report, we have adjusted all of our birth rates for loss, which makes a lot more workforce that's required. And as far as I'm aware, nobody's done that before. And it's absolutely essential, and it's something that all local areas and commissioners need to do, and that we can campaign for if we're to include those people. Because they are also, after loss, we know, particularly loss before 24 weeks, we know that people are frequently pregnant again within 12 months. And the burden of mental health is significant. So it's, again, an early intervention. If we can capture them and support them earlier, then we're preventing perinatal mental health difficulties down the line. So it is something that is invisible, but we are aware of, and that it is absolutely central to our report.
Thanks very much, Camilla. Thank you.
Yes. Right, we've got a few comments from the audience. So Laura Kirk-Smith, MP, who I know wanted to be here, but obviously has been prevented from joining us live, has been joining us online, and she wants to highlight that early, from a politician's point of view, that early detection of mental health risks is absolutely key, and rapid onward referral. But to get government to support expanded work, we need to make not just the human and societal argument, but the economic argument. So that's reinforcing that kind of tripartite approach to campaigning for improvements. And then we have a comment from Laura Spence and a question. I wanted to highlight that we need better data, re maternal suicide and attempted suicide. For example, women with ADHD are 5 times more likely to attempt suicide, and this number is higher in autistic populations. So why are we not connecting the data regarding this and maternal suicide? I know that the inquiry into maternal suicides looks very closely at all recorded information across all primary care and secondary care records. I think that's still true to say, isn't it, Alison? But the numbers, of course, are relatively small, and so making statistically significant inferences is very difficult. But I think one of the things that this highlights is that we talk very little about both the mums and the babies who have disabilities. And we really haven't even started that conversation, and there are multiple needs. And we were hearing about babies in neonatal intensive care units and their futures, and how they're even more vulnerable to both their parents and them to the impact of mental health difficulties, and even more in need of support. There are many, many groups who need very careful individual attention and tailored care. And we can only achieve that if we all work together. It seems completely obvious that these families, at the very least, need services that are paid for by the public purse to bloody well work together and function together. And of course, that's how Henry Ford achieved his great empire, wasn't it? With real collaborative working. Sorry, I don't know why I bring in American industrialists. But there's some quotes from him. Anyway. Yes, you did. Sumli Hazar from Calcutta. My question is, do new mothers and mothers of adult children occupy the same space of attention? If not, what can we do about it? So motherhood doesn't end in the perinatal period. It doesn't end at age 16. I know to my cost it doesn't end at the age of 40. So very nicely put point there, I think, Sumili. It carries on. But if we can get the start right, is it not the case that if we can at least do that, we can set people on a trajectory? We certainly know that with babies, don't we? And I think, Eamon, you're a leading expert in this. Trajectories for babies start at conception, effectively. And if we can get it right early on, we can really nudge things in the right direction. Is that fair to say?
That's fair to say, Alan. I wouldn't disagree. Because as you know, Alan, just very briefly, so Alan's, I think, just referring to the neuroscience that I'm sure all very familiar with, is the incredible plasticity of the brain right from conception, and the extraordinary impact. And that's why the first 1001 days is so important, that plasticity really is massively informed by the relational experience of the child. And that, of course, is often the mother and the primary caregivers around the child and the baby. And my own work has been on the impact of early adversity and trauma, and we see how those brain systems are calibrated in those initial years of life and set and train almost self-reinforcing patterns of feeling, of thinking, of behaving, and of relational interaction with others that can be adaptive and positively reinforcing, or they can be problematic as problems compound on each other. And it sounds very complex. The neuroscience can make it look complicated, but it's very, very simple. It's for a child to feel loved, to feel secure, and to feel have an adult who's curious about their mind as an individual. And that's what we need to support mums to be able to do in terms of having the support, the wraparound support that Camilla was talking about, but also having the practical support and not being so preoccupied by the bills and all of the other things they're having to manage at the same time.
Yeah, brilliant. Thank you very much, Eamon. And don't we all know it? When we're under stress, we just can't function that well, can we? And we can't be that sensitive to other human beings. And that's what we need to be and want to be. I've never come across a parent who doesn't want to be a good parent. Never come across it. But lots who find it incredibly difficult. And surely we have a responsibility to do something about that. So we've got another 3 or 4 minutes. If we've got any more questions, either from the floor or comments, indeed. Yes.
Hi, I'm going to take us right back to Camilla's slide of Spaghetti Junction. My name's Kath. I work in the Birmingham Perinatal Services alongside Elizabeth. Spaghetti Junction, of which Birmingham is incredibly proud. When you look at it from the outside, you don't know what to do with it. It's extremely intimidating. If you know Spaghetti Junction and you know the signs and you know the right route to take, you've got sat nav, it's a piece of cake and it gets you to where you need to go. And what we need to do while we're working on these services, while we're looking at integration, is we need the people who know where to go, and we need the people who stood at the outside feeling terrified about it, and we need to listen to them. And that's your lived experience. It's also your peer support workers. I don't think it's any coincidence that within Birmingham Maternity Services, our peer support workers in the maternity wards themselves are called maternity navigators. And it's for that reason. They are your sat nav, they know the signposts, they will be able to show you the bits that work, the bits that don't, the shortcuts, the local knowledge. And I'd absolutely implore you on every single level to use them. And you know how long I've been beating that particular drum, and it's why I'm here today. So yeah, I just wanted to mention that, and thank you for shining a light on Spaghetti Junction.
Thank you very much. Yes, we hadn't heard about peer support workers. I was in Brussels last week talking to Belgium, a large group of perinatal mental health workers in Belgium who are just beginning to introduce the notion of peer support workers and are amazed at the potential for good that they can bring. And of course, that's a huge overlap with the contribution of people with lived experience throughout the system, including today, for which we're very grateful. So we're actually, how are we doing for time? We're 1 minute left, so there is time for one incredibly quick comment, and then we're going to move on. So, last one.
Thank you very much. I'm Sakina Ballard. I'm actually a trustee at the MMHA. I'm also the lead for perinatal peer support at CNWL. I guess it's a bit of a question, but there isn't time for a question, so it's more just a reflection. When we're talking about integration and we're thinking about inequities, I guess one of the things I also want to think about is how we start to integrate psychological or recovery frameworks that are culturally sensitive and competent, because we know in terms of inequities in mental health that we are seeing not enough representation at mild to moderate, let's use a sort of language we've been using, and an over-representation, particularly in acute services. And we know that's also reflected in maternal mental health, and we know the perinatal outcomes. So I guess it's also that reflection of not just how do we integrate the services, but how do we integrate and kind of working towards recovery that feels safe and approachable for, you know, the diversity of people that we need to serve, particularly mothers.
And of course, one of the joys of an integrated model is that actually all of us should be facing that challenge together in the currently physical health maternity care, in mental health care, throughout all levels of need and throughout the population, with dads as well as with mums. So if we work together, surely we can start to get that richness of approach built into our system. Thank you for that. And that really concludes the questions and answers. And I'm sorry out there that you didn't see the faces of the wonderful wonderful, really erudite contributors to this discussion, and thank you for participating out there. We're going to, our last kind of agenda item is that Baroness Maron, who is the Minister for Women's Health and the Minister for Mental Health, was very keen to attend today, but unfortunately wasn't able to during long-standing prior commitments, but she volunteered to do a short video clip for us, as she said in her email to me, to show her support for this issue and for finding solutions. So hopefully we've got the technology to play this clip. We've got about 5 people working on it and still discussing it, so I'm a little bit nervous, but let's try.
I'm Gillian Maron, the Minister for Women's Health and Mental Health. And I'm sorry I can't join you today, but I was very keen to send this message because this whole area is so important. Pregnancy and parenthood should be one of the happiest times in a family's life, but it can also be one of the most challenging. Women and families deserve all the help they can get before and after their baby is born. So this government is investing in mental health services with an extra £688 million this year alone. And we are committed to 8,500 more mental health workers, and 165 mother and baby unit beds have been commissioned for women who go through severe mental health crises during and after pregnancy. And we've made specialist perinatal and maternal mental health services available in all ICB areas of England. The most recent statistics show that more parents than ever before, including those who have gone through the tragedy of losing a baby, were able to get help from these services last year. And in the 12-month period that ended in October, well over 66,000 people were in contact with specialist perinatal mental health community services, 6% more than the same period the year before. But of course, there is so much more to be done, not least on the appalling inequalities that Black and ethnic minority women face in maternity care. This government does not bury its head in the sand or pretend that everything's rosy when there are big challenges out there, which is why Wes Streeting, Secretary of State, appointed Baroness Amos to lead an investigation into NHS maternity and neonatal services to help us understand the systemic issues behind why so many women, babies and families don't receive the care they need and deserve. The investigation is looking at care given across the country and will bring together the findings of past reviews into one clear national set of recommendations. Just last week, Baroness Amos launched a call for evidence, and I would urge you to share your experiences in that survey if you feel able. Baroness Amos wants to hear from a range of women who have gone through maternity care, as well as anyone, fathers, partners, whoever who may have supported someone through maternity care. And the Secretary of State is setting up a national maternity and neonatal task force, which he will personally chair, to develop a national action plan based on these recommendations that the investigation will make this spring. We have been clear we want a relentless focus on improving outcomes for women and babies. We will hold the system to account, and families will be involved at every level to ensure that they receive the care they expect and deserve. This is too important to leave to chance, and so I'm grateful to all of you and the Maternal Mental Health Alliance for doing your bit to put this at the top of our national conversation. I hope you'll keep doing that. Thank you.
Will we keep doing that?
Yes.
I will. So, yeah, I mean, you can cut all the kind of obvious political stuff about we're already doing wonderful things, which is actually, it's not untrue, but I think there are things to focus on there. And I think the last message is a call to action that we would have done if she hadn't done it. Which is give evidence, okay? Please, all of you, give evidence. We see the slide.
Yes.
Give evidence to this national inquiry on the issue of mental, because the national inquiry was set up with horrific physical health problems in mind, and we want to make sure that it doesn't forget that mental health is, as we heard from Alison, a huge killer as well as a cause of huge amount of suffering. And she did mention fathers as supporters, but we need to get fathers in there as sufferers as well as supporters. And I think that's really important. She mentioned diversity. We need to get the special needs of people from diverse populations into that consideration within the context of mental health. And we absolutely need to say, please say there is a solution. If we don't say there's a solution that is possible, then they'll find that a great excuse to ignore it. Promise that we can all work together to arrive at that solution, to really transform things. I hear on the radio governments saying, politicians saying, oh yeah, we're going to invest in the NHS, but only if there's transformation. There has to be reform and transform. Well, let's offer them to it on a plate. We won't invest, yes, and we'll give you in return the best maternity services in the world, the only ones in the world. And not just, thank you, not just at maternity, but through that vehicle, the whole of universal care services around this time, the best in the world, because it will be both physical and mental health working together in a holistic way. I started my training in medicine in obstetrics, in fact, not psychiatry. And what I encountered in obstetrics that led me to switch to psychiatry was that all the professionals I worked with in the East End of London totally got that mental health was an issue. But the mental health professionals in mental health services didn't give a shit and didn't respond to referrals. And the obstetricians and the midwives said, we do our best, but what can we do? The most wonderful thing I learned from the midwife was going out on a visit as an SHO in obstetrics. And she said, I'll tell you the most important thing I do as a midwife. And she took me and the mum we'd just visited to 2 doors down and introduced that mum to another mum who just had a baby 2 doors down, who she didn't know was there, and said, you didn't know, I just visited both of you, but you didn't know each other. And now I'm introducing you so you can support each other. And we'd like the whole of society to support each other. That midwife said to me, that's the most important thing I do in my work, is network, because I'm only a drop in the ocean in terms of time, but they're dealing with it all of the time. And I've taken that with me throughout my career. I thought she was the most wise and wonderful clinician I'd ever come across. Anyway, I switched to psychiatry, and that was the end of that story. So please give evidence to Baroness Amos, and we've heard that the MMHA is going to be organising a round table to interface with that inquiry, haven't we, Nikki?
Yes.
And I'm sure that many of you senior people in this field are going to be participating once the inquiry is over in the, oh God, the word slipped out of my head. What's it going to be? Sorry?
Task force.
The task force, sorry, yes, exactly. Sorry, my hearing's gone as well as my brain. Participating in the task force. So please, in the task force, shout loud and clear, we can do something about this. I think I've got to shut up now.
Yes, and I want to just say,
all right,
if I may.
Yeah, so I could carry on for hours. Thank you very much.
Could you please put your hands together for Alain Gregoire? Thank yous. I said something the other day and he said, oh no, us Anglo-Saxons, no, we don't do grand effusive thank yous. That's the continentals. MMM take note. Thank you, Alain. We met back in 2025 in September when Make Mothers Matter presented.
Don't do the effusive histories and thank yous, they want to go.
Yeah.
Cup of tea.
I got 30 seconds. At the European Parliament, and that's where the idea for this event came together. So we do thank you for the vision, for your enthusiasm. We thank Annette, LSC CPEC, because without her, we wouldn't all be here. I want to thank your team, Joe, Alberto, and Daniel. Coming to Camilla. I'm getting my wrist slapped. Obviously, Camilla, we've been talking to each other at meetings and ideas, and her team, Georgia, who's been an absolute terrific support. And also may I thank Valerie and Ariane from Make Mothers Matter, our colleagues who've been helping today. So thank you to all of you. Thank you, our live audience. A lot of lessons learned, a lot of work to do. And I think your final word on let's just make a noise, as somebody said, you said, the anger should drive us to say, no, it shouldn't be getting worse. Why are we still talking about it? So thank you for all your good points and have a wonderful evening. Don't forget to leave your lanyards outside. Thanks, everyone.